didn't guess. So we start off with just an overview of it. So the organization of the nervous system, how is it organized itself, how does it work, and all that good stuff. Then after this, we actually get the brain, spinal cord. We break everything down. So with this overview, so central system, peripheral system. And our central system is the spinal cord, the peripheral system, cranial nerves, spinal nerves. Okay? And we have 12 paired cranial nerves, 31 paired spinal nerves when we actually get there. All right, so we'll go even further with this. It's only in PowerPoints. Sensory means we're going to take the information from the outside world and bring it to the inside world. So from the peripheral to the central. And then the motor system means we're taking the information from the brain back to the outside. So an effect would cause an effect. Afferent system versus efferent system. Okay, in the motor system, we have two breakdowns. We have a voluntary system, which is primarily your skeletal muscle system, to walk around, make movements, so forth. Then we have an involuntary system, which is your cardiac and smooth. Which is, so what's that going to do? Well, even there we could add glandular function. That's a sympathetic, parasympathetic system. So what's the sympathetic? Mrs. Robinson. See, Mrs. Robinson. Good afternoon. Is it lunchtime yet? No. Okay. That's disruption. So in the sympathetic system, that's what system? Your fight-flight system. Fighter, get the hell out of there, right? Parasympathetic is rest and digest. Think about after you've pigged out on a holiday, and all you do is plump on the couch and wish the food would move. You say, why did I put so much in me? You have a plunger, you're looking at your bottom half and plunge it out. So let's go. And it feels like cement. From this point to this point, like somebody cemented the GI tract solidly shut. So those are the two major autonomic systems. So the key, as you've seen, they come under neuroses. So when you text, you have this nice flow chart. So again, this system here, brain, spinal cord, don't worry about that on its own entity because it's kind of detailed. Peripheral system, well, we go to the sensory or the afferent system, motor, efferent system. Effect creates an effect. That's like in your English classes. You know, they're looking at an effect on. That's right, you're not on video showing instructions. You're going to be on national, international news. The lady who disrupted CCRI and okay, so the sensory system, somatic versus visceral. So we break it down even further. Somatic is your body. So kind of sensory, touch, pain, pressure, all goes kind of together. You couple them together. That you're aware of someone, you know, is something blunt touching me or is that knife touching me? So that's what you can say by intensity of it. Is it painful or is it okay? You can deal with it. You know. So these three would go together. So touch and pressure. How much pressure? Is he squeezing the hell out of me or is it light pressure? So that still would come under the category of touch, which is nociceptus, to pick up that sensation. All right, so that's what we mean by that. Vibration and temperature would kind of go together in the spinal thalamic tracts. They play with that, such as vibratory sense. You know, I take a pruning fork and I put it on your joint. You're aware of it there. You can sense it. That's vibration sense. The other one would be temperature. You can tell something's hot or cold touching you. This would be a spinal thalamic tract. So in other words, they're going to the thalamus part of the brain, which we're going to see as we get into the brain. The main window is proprioception. What do we mean by proprioception? Her eyes are low. Even the quiet ones get bothered eventually. Okay, so what do you think of proprioception? What do you think of proprioception?
Conscious perception of movement and spatial.
That's right, there you go. In other words, you always know where you are in space and time. If this was a totally dark room, would you be aware you're sitting, standing, or lying down? Yes. You would know if you were upside down if the room lights were on. Your body would be aware of that. So you don't need your eyes and light perception to realize proprioception. So in other words, you know where your arms are right now. You don't have to go, oh, there it is. Thank God, I couldn't find it, right? It's still there. You don't have to say, okay, where are my arms? No, they're here. I know they're out to the side. So you're aware of that. Skin proprioception would be what? What do you think with skin?
The little hairs.
Well, you can sense something there, touching. It's not even touching you yet, but you know it's there. Or more than one point touching you, 2-point, 3-point discrimination. Proprioception. I touch me with one finger, 2 fingers. And you can fake the nervous system out, which you'll learn when you take Viz. You do a sensory lab, and you have this, looks like a protractor thing. And you bring it. The thing will almost be an inch apart. You say, okay, I'm going to feel 1 point touching you. Now, if you were to come straight in and poke, you'd be aware of it. But while it's on you and you're moving it closer, you lose your awareness of the proprioception of, is it 1 or 2 touching you? It's hard for the body to delineate that. Now, if it was a blind person, they might delineate a little better than you because they're relying on that sense more than you. So this depends on what senses you have and what ones you've lost.
Spatial awareness so much depends on your area.
Yes. For balance.
How does that wired into your nervous system?
We'll get to that in a second. You're jumping the gun. We're going to get to that when I get to look at the other box. See the bottom?
Yeah.
And well, we're not the bottom, I mean the bottom of this box. See here, equilibrium. We're not there yet. Move the story. Speaking of lost, that boy died. Hashtag D-Strong and died last night. Yeah, Dorian, from Westerly, he died. Life stinks. I guess it was liver failure.
But I thought he had.
He did, yeah, I think it was.
He died of liver failure.
Yeah. That's sad. But he got famous. So she made a good point. How is hearing equilibrium hooked into this system? Well, first of all, they come through one nerve. The vestibulocochlear nerve, which is cranial nerve 8, controls your inner ear, such as for hearing and for balance. And it'll go to receptor sites in the brain. And how this ties to the whole body? Well, it ties to a major tract in your body called the dorsal columns. The dorsal columns, there's 4 major tracts you always test on something. You know, the corticospinal, the spinal phalanx, ventrolateral, and the dorsal columns. When you do a basic neurological quick check on a patient, you're looking at these 4 major tracts leaving the brain, and they tell a lot. Well, the dorsal columns are kind of your proprioceptive tracts. And that's why someone that can get tertiary diabetes or tertiary syphilis, which doesn't exist that much anymore today, in other words, they lose their awareness of where they're from. So when they walk, they'll walk like this. Because they don't really know where they're throwing their foot, so they stomp it. And eventually they get an X-ray they call Charcot joints. The joint destroys itself in this constant fashion. Okay, so the syphilis one, the gonorrhea is not that common anymore today because of antibiotics. But the tertiary diabetic ones still can exist, even though they have a better job of controlling diabetes today. That's a person who wants to be controlled. So what it does, the dorsal columns are in the posterior aspect of the spinal cord, and that gives you awareness sense. This nerve, as up in the brain centers, will connect to it. So they all need to be labeled one another. Most likely in the superior aspect of the brainstem and the diencephalon where all this connection will take place. Because you don't have to look at your feet to know you're walking okay. It becomes a good learned response. And we'll get into that eventually, how we can see that with reflex and stuff. But you don't have to like, let me see where this foot's going.
Well, we're talking people that are less coordinated.
Well, yeah, eventually you can get nerve, but now if you have dorsal column disease, the person falls over easy. I mean, you get older patients that'll get this over time as they start getting dementia changes to the brain. That also will affect this arm. So you actually say, okay, let's do a Romberg sign, put the feet together, over they go. You know, it's like kind of like they look like a drunk person. And they're not drunk and they're not drugged, it's just the brain, it's starting to go. So these centers are getting damaged that are not proprioceptive like they used to be.
Can people be born with variations though?
Yes.
Some people are like naturally a lot more coordinated.
Yes.
Right? So
Yes.
there's some genetic.
There is, oh yeah, there's all genetic.
Yeah, but it's like your central nervous system. I can't
Yeah, I mean, some people like you better than others.
remember. Yeah.
Same difference. So, good point. No, but again, just like dogs, aren't there dogs smarter than other dogs? They're not all created equal. You know, you can buy get your first dog, and great as hell. Trained it and them doing it in a week. The next one you get takes months. The thing still keeps messing in the house and all this. You know, it depends. You know, and sometimes there's stubbornness in there too. But the dorsal columns can get, so that's, you know, we'll look at this more at this when we get into the spinal cord, but this is a major column that gives you proprioception. That's how this cranial nerve ties to it. So people with Meniere's disease, don't they have balance disturbances as well as the ringing in their ears? Yes,
Sure.
they do. You can put all the bioflavonoid you want, and the tinnitus doesn't stop. They go nuts. I mean, I've had patients with that. They just constantly in their ears, they go crazy after. Eventually, they get used to the sound. But there is slight hearing loss. All these different things happen with these people. You know, could have been viral induced, maybe.
Why is it made worse by a high salt diet?
High salt diet does what?
It says it worsens the nerve.
Why? What do you think? What salt going to do to your body? You take more fluid build up, more pressure build up in the end of the affect it. Yes.
My mom has that right now.
Yeah.
She's trying to move it on.
Yeah. But she has, ear specialist.
Yeah.
Usually it's neuroania specialist connected. I have it. No matter what the heck you did to this person, you couldn't get rid of it.
Yeah, I don't think it's like.
No, it's not curable. It really isn't. It's like this computer's not curable. It's not curable. Unfortunately, it's not. You can improve it a bit, but it's not curable. They'll be able to help her out. Could have been a virus. Labyrinthitis could have started it. The virus got in there. The person they can't stand up and move because they picked it up, and it could actually do disruption and damage when that happens.
Yeah, she had a cold.
Right, there you go.
And then it
It started
started going.
after that.
That's really-
They complicate and settle at the inner ear. You ever see somebody with true inner ear disorder, they can't even get out of bed, they're spinning everything. It's like when you're drunk, everyone just starts spinning, it's like, whoa, you have to pull out like this. Before the vomiting comes, right? So that's where that would come in. Vision helps. Someone that has Meniere's, it depends a lot on their vision to keep their balance. Because you close their eyes, they move. If it's really severe dorsal column disease, eyes in or not, over they go, they still can't tell. But on mild to moderate cases, vision does help. So you do a Romberg test. Romberg, put the feet together, close the eyes, they put their hands on, okay, close your eyes. Person goes, oh, and you get drift. The arm will drift on the side of the lesion, so they drift. That's what they mean by drift in the neurological report. That's affecting the dorsal column. Now, do you know what's doing it? No. Could be a tumor, could be anything, could be MS, could be anything causing this to happen to you. So many things can affect it, okay? But it's the dorsal aspect. So any disease that can affect the dorsal column would cause a problem, okay? And diabetes is a big condition to affect. So now we look at the visceral sensory. So that's somatic sensory. That's your body awareness. Visceral sensory. Well, in the stomach, you really can't touch your stomach, touch your intestine. It doesn't really have touch receptors. To pick up this change in it for pain, it's stretch receptors. So they stretch. So when an organ overstretches, you know about it. You're like, whoa. Oh, I feel lousy. I'm all blowy and I think I'm going to throw up, vagal stimulation, cut the vagus nerve, it won't throw up. A lot of things won't work the way if you do that. So we're going to respond to stretch versus that type of pressure. So it's a stretch pressure, it's different, because you can't poke it. It has temperature change. You know if you swallow something hot or cold. It reacts to chemical change. Reflux. You know what's happening when it's hitting your esophagus, right? Or, you know, you're flaming diarrhea, you know that's happening too. Too much spicy food, right? Hot going in, hot coming out. Next day the toilet paper catches on fire, you're wiping. But, so we do have those receptors, we know something's going on in there. So we may not like it, but it's going on. So we can, you know, it'll pick up irritation. And the irritation can make you feel nauseous or make you hungry. So that's that awareness. So this awareness of hunger, something going on, is like the proprioception of your gut. To know something's changed in there. So then we have the nausea and the hunger, which goes along with it. So taste and smell, we kind of categorize it with the GI tract more so than, you know, so you get your special senses where years ago they just stuck it all in one. Now they kind of categorize this one here, taste and smell, with the visceral function, which kind of makes sense, because if it smells funny, you usually don't taste that way. Sometimes, you know, or it can smell good, but taste it a little bit, you know. So you know, like coffee smells better than it tastes. You know, it's just like pipe. Someone smoking a pipe. It's not common today, but you know, not the wacky tobacco. You know, I'm talking about. You know, they have the flavored tobaccos, and you smell it. It smells good, but taste it tastes like ugh. It doesn't taste good. You know, so the point is. But they kind of work together. If you lose your sense of smell, things don't taste the same. Or if your taste buds are a little off, you know, it doesn't smell the same as you're chewing on it. So they relate to one another. So that's why we categorize them. Yeah, they're mainly chemoreceptors, what they are. They're picking up chemical shifts. Then you can taste or smell. So they're not noceo, they're chemoreceptors. So that's what you find in the tongue. And different nerves would control them, which we'll learn when we get into all the cranial nerves. So now on the other side of the fence, we have the motor system. And we have somatic motor, which is pretty much a skeletal muscle. Are there some skeletal muscles though, that work off the autonomic system?
Yes.
Who said yes? Yes. Okay. You're right. Do you have an idea?
No, I just figured out yes.
What? Your eyes? Well, your blink response, right? You have to think about blinking? No, that's one. How about swallowing? You swallow while you're sleeping? Yes. That's why you swallow spider and things like sleeping at night. Biology books all say that. We swallow 1 to 2 spiders a year while you're sleeping. And they crawl your mouth down the toes.
Is your heart?
No, that's not
No, I
skeletal
know.
muscles. Come on, you even asked that.
I know.
How about the diaphragm? That's skeletal muscle. And it's a spinal nerve that controls the diaphragm, believe it or not, and it's all autonomic. We'll learn about that. We'll learn about the phrenic nerve. We'll actually see it in the cats, for those who like cats. So, you know, if you don't like the cat, you can look at it on PAL just to get an idea of what these things look like, so you don't have to really deal with the creature. Because that's how it'll be in the fall. There'll be no creatures anymore in labs, because the lab will be up here in one of these rooms.
Are you serious?
Yeah.
That's,
We have to do that for a whole year and a half, because the labs will be in Vermont. And you can't bring chemicals up here. We're not designed for it, so they'll be all virtual. I'm working on it now, it's a pain in the ass.
well, you get
One lab takes an hour to set up, just to set the damn thing up. For people to look at stuff and then answer questions. So instead of having homework assignments next fall, they will have lab assignments, a minimum of 10 that will be using visceral stuff. That, you know, because the first few are tissues and bones are what you can do, which is the first 4 weeks. But for the next 8 weeks, they'd have to use that plus have lab. So that whole section will come as one So, and it is timed, and if it's not done on time, you get a 0. That's just the way it is. What are you two guys together hanging out?
We're both equally late.
Is that what it is?
Yeah.
You didn't woke up last night, right? Just curious, that's all. Just FYI. I had a student a couple of semesters ago, we were just sisters, and one, the younger one would always be late, and he'd be like, what were you doing last night? Shut up, leave me alone. And she'd just sit down and because I'd have to ride her to go in. Unless they called them sister, too, like that show that was on. That was their name in lab, sister. But now we come over to the autonomic system. Now your heart and your smooth muscle and your glandular function would be working here. So we're going to increase the activity or decrease the activity of it. Simple as that. So in the autonomic system, what would be smooth muscle that we're stimulating? What do you think? Your stomach, right. Anything that's lining a hollow organ is smooth muscle, including blood vessels and so forth. That's all working from here. Okay? Automatically works over your brainstem. You're going to see when we get into the brain. It'll increase its activity or decrease it. So the majority of your parasympathetic system in the viscera, especially from your head, neck, down to about the proximal third of the large intestine, is all controlled by vagus nerve. You're going to see when we talk about the vagus. The term vagus means wander. So it's the longest cranial nerve in the body. And this nerve will make it down to the ascending colon. That's how long it is. The rest of the colon is innervated by the sacral plexus. But that's how much vagal stimulation there is. That's why someone with, an older person with congestive heart failure, or really weak heart, probably pumping at like about 18% of their lucky, really is on the pooper, bearing down too hard, and they, over they go and they drop dead. Why? Because the vagus gets overstimulated and shuts the heart down, and they die. That's the last thing they need. So it's nice. They died on the pooper. I remember years ago we had a person that we picked up from the VA hospital, and the cause of death on the death certificate was diarrhea. Dysentery. So we looked at one another and said, that's going to be with you forever in records. What killed you, diarrhea killed me. And we said, oh my God. Not something like, oh, how did I know? They couldn't stop it. He just finally crapped himself to death. It's sad, but true.
People used to do that all the time.
Yes. Well, they didn't realize it was bacteria probably creating the problem down there. They didn't treat it, and people died. Before the advent of antibiotic and stuff, it was very hard to control a lot of diseases that were out there. It just took a lot of people. Certain things you got, you died.
Coming back to that, it's gonna be like in our lifetime.
It will come back because
There
the
are
only thing that's going
things
to change,
that work.
the only thing that's going to change it is they'll genetically know how to change the cells to fight all stuff. You won't even need antibiotic anymore. That's future
God,
goes
thank
on.
God we're getting there.
And that day will come. And when they can hit that gene that they can get to that ability, you're going to see a lot of diseases gone. And then the stem cells to replace it. So the future of medicine, like 20 years from now, isn't what you're being taught. It's going to be totally different. You're going to look at some of the stuff, the way we treated cancer, how barbaric. You actually used to put this crap in people. The cure is more deadly than the disease sometimes when it comes to treating cancer. Because later on they get the cancer down, they die of organ failure because the chemo was so toxic it destroys the heart, liver, or kidneys. So they only can take so much. And we'll see that as it goes on, that it's going to be a genetic way of treating it, not. But we can't cure it yet. If we cure it, Look at the way standards keep changing. Oh no, if this, you're treated. Come on, that's bull crap. It's pharmaceutical industries dictating what value should be and what we should be treating to sell more meds. So let's sell as many as we can over the next decades before things change. I hate to say it, but that's the way it goes. But she's right, eventually you're going to get superbugs. Look at this Zika virus thing going around. I wouldn't even be in the Olympics if it was me. I wouldn't even take the chance of going down there. Imagine getting Guillain-Barré syndrome because of it. Some people can. And if your immune system's a little off that time and you pick it up, you'll die.
That's scary. Okay, but have you read about the fact that there are only reported cases of microencephalopathy in Colombia where they just began trying to control the mosquito?
Oh yeah, they're trying to control the mosquito pop, but now they're saying the microcephaly may not be due to the virus. They say it may be due to the insecticides they're using to control the mosquito
The virus is
population.
widespread, it's all over South
It's
America.
it's always there. And the type of mosquito that carries it doesn't live here, but there is another variant of that mosquito that you come up here with. You're gonna see it. No, you're gonna see it come up here. Spring break. College kids are gonna go down there, and you're gonna get it. Because most people, 80% of the population don't even know you have the thing.
Yeah.
And it doesn't really do anything to you. But the mosquito bites you, now goes and bites someone else, it carries by you, or you just have a good old time down there, and then you have a good old time up here, and you spread it sexually. Without us seeing that it's spreading that way, which they weren't aware of.
Oh,
They weren't aware of that. No, the first case was ever found was in Texas about a month ago. They didn't think it spread that way. They thought it was only true blood because of the mosquito carrying it.
yeah.
Now they realize, uh-oh. Yeah. Well, no, that's called population control in this country. They just say it is. They just don't have the money to support everybody. There's no other system like here. So we have, what was yesterday? International Women's Day, right? Yes. That really applies big to this country and Canada and stuff, but some areas of the world where women were doing that, probably when the Canadians went away, they probably took them and stoned them because they're so still prehistoric and backwards. You know, it's sad that you have to have these things that, you know, aren't we on the same level with one another? I think women are better, really, so they can make decisions.
I saw a post on Facebook about how due to Women's Day, about I think it was 90% of the women stopped and their work and left their homes and protested, and then a year later they got women's rights.
Yeah, so in some areas it does work. It does, you know. But happy National Internet, I didn't even know. I didn't know it existed. I mean, I wasn't on the computer looking at that stuff. You know, I'm one day just looking and mastering AP and all that other crap. So you're not going to show me that I'm mastering AP. So boring it is in that office doing stuff like that. You're ready to throw the computers for the window. This stuff I hate doing, I gotta do now because there's so much this. But here we go. Sensory motor interneuron. There's three types of neurons. Probably like, what the hell has this got to do with anything? Nothing. But there's three types of neurons in the body. You have a sensory neuron. What is a neuron? Well, it's a nerve cell. Okay. Sensory motor interneuron. Well, the motor one. Notice what I'm saying. The cell body will sit outside the spinal cord. It's outside. And I'm going to show you that in the schematic in a second. So just go with me on this. And it's in the dorsal aspect. So if you have a spinal cord and you draw an equator across it, anything posterior to that line would be sensory, anything anterior to the line would be motor. That's the way our spinal cord breaks down. Okay, it's as simple as that. So the motor side, the cell body will sit inside. It's within the spinal cord. Then we find out we have these other type of neurons known as interneurons, and their job is to integrate information. They design your neural pathways. And what they're going to do, you're going to find mainly they're going to be in the dorsal aspect of the spinal cord and throughout the brain. And the interneurons make up over 99% of your neurons. The other 1% are the other two types. Because you really don't have that much need for the other two types as the interneuron. So the easiest way to understand how this system works, if we can, we look at this picture about it. Well, here it is. So if I was to draw an artificial line across here, right down to where we come to the spinal nerve, right through here. See this thing called the dorsal root ganglion? When you see a ganglion, the swollen area in the nerve, that's like where the plug is. That's where the cell body sits. So what happens, it's kind of like when we made the sensory system, we kind of screwed up and then make the wire long enough, so we had that little wire to make it to the end. So it's like we have an extension cord, and it's like, damn, it only gets to here. So I gotta get another small one to hook it to here. That's kind of how it looks to get inside the spinal cord. So nature messed up. No, not really, but that's kind of what it looks like. So this thing here is my cell body for sensory. It's over here, the plug. Then it has a little wire that goes from here to meet on an interneuron to take it to the brain. So this would be known as the dorsal ganglion, and this is the dorsal root. And if you had asked anything about either one of those things, they're primarily sensory. That's what they do. They bring information in. So the arrow would be going in this direction to bring it in. When it gets inside the spinal cord finally, that little piece of axon is going to synapse on an interneuron. It would be a sensory interneuron, either for somatic sensory or visceral sensory. That's what SS and VS stand for. So depending on what's bringing it in, you see the deeper in would be the visceral, and the furthermore, the periphery would be the somatic on the sensory surface. So that information then will send up to the brain, and then the brain will integrate it in the association areas. What do I do with it? Do I kick it over to the motor side, or we just let it go? You're sitting like this. Well, this is cool. What's happening after you move your hand? So your brain is aware that it's cool, but it's not dangerous to you. So there's going to be no motor response. So the brain took the information and decided what to do with it. But if it's something that's going to react against it, it'll kick it over to the motor centers, and then it'll descend down the cord onto a motor neuron, out, and you pull your hand over it. So it's kind of like the computer. Your key panel or your keyboard is the sensory part. You're feeding the information into the processor. The processor is the integrator, taking it, and you see the little thing when you're going online, you Google search, you see the thing going, but that little thing goes, what it's doing, the computer's integrating the information. When it finally kicks it to your screen that you are where you want to be, that's your motor response. The computer responded back to you with an answer. So it works like a brain, same way we are. So your nervous system is nothing but designed similar to this computer system. So you have input in, integrated, input out. Simple as that. So it goes in, integrate, out. So sensory brings it in, the interneuron's integrated, the motor brings it out. And it's as simple as that, the system. If you keep it that simple, it's very easy to understand. So you're looking at this stuff, and you say, wow, that's pretty cool. So we know all our motor functions here, visceral motor, somatic motor, and you kind of see the motor, when you're dealing with visceral, they're kind of more centered on the cord. And the more peripheral of the cord is going to be just, somatic functions, because they're going to have to react quickly to get out quick. So you see in that setup, the way they're designed, now you can see why diseases like polio would wipe out your respiratory centers. How would it do it? Not even in the brain, but it could do it in the spinal cord. It destroys the anterior horn, which is this. So if I lose this, not only am I paralyzed, I can't breathe. So these people went dying lung.
There's still a guy in my lung. I just read about him. He's a lawyer.
That's amazing.
It's really.
That is amazing. That they live that long, that disease
Yeah.
can set in and finish him off because everything else is falling apart.
Well,
But that was a scary disease in the 50s. People became paralyzed. And now that people that overcame it, that had polio but overcame it, have come down with post-polio syndrome, where they have neurological residual from the polio. And I had cases of that. I was one of the first ones to diagnose it. Because I asked the person right out, I said, "Yeah, I have polio as a kid." She said, "Yeah, I did. I was put up in the wrong way to the, no, that was for TV, but she was put in, there was a hospital on Broadway, which don't exist anymore, but she was put there as a child and stuff for like a month. And then, to keep an eye on her, and her father bought a beach house for her, and put her in the fresh air and stuff. And she had that, because she had these weird neurological signs and symptoms that didn't fit anything else. It's like some motor weakness, intensified sensory discomfort. And so I asked her, I said, "Do you ever have polio?" She said, "Yeah." And it was weird, because I read an interesting journal article on it about a week before this patient stumbled in and remembered some of these key things. And I said, "You probably have residual polio, which is going to cause other problems in you as you get older." So you do have some of your clientele on in this. 70s, mid-70s, in that point, that might have this condition. Anything post that really wouldn't, because they kind of eradicated the disease with vaccinations. Until people stop vaccinating, and it comes back. When you eradicate it, it doesn't even kill it, you stopped it from spreading in a certain population because it can't live in those people, but it's still there. So when you don't immunize, it comes back. And when it comes back, it usually comes back that it's changed itself, that the vaccination is not working. So you make the disease more violent, which is worse. So much on that. But for those who don't believe in vaccinating, well, this is the reason why you should, because yes, there's always side effects to anything you do, but most of these other diseases will take you if you get them. So that's the reason. So you gotta weigh out, is the cure worth it against what the disease you do? And if the answer is yes, so then you do it. If the answer is no, then you don't do it. It's like if you have something fatal in you with cancer, and you ask them right out, well, doing this type of barbaric therapy, what is my cure rate? It's not 90%, it makes it a 50-50 shot to me is not worth it. The disease itself is going to be less harmful. Now they realize with triple negative breast cancer, if you treat them with nothing, the outcome is the same as treating them with Japanese chemos, because it has no effect on the tumor. The person will probably live the same amount of time, more quality of life than the chemotherapy. Because they're finding that it's one of the ones that's so damn resistant, and it's a tumor that's so intelligent, it changes and modifies its DNA against every chemo that comes up against it, that it overcomes it. So it's a nasty situation, but that's life. Before we go into this, I want to get back up here now. Let's look, this is this top neuron right here. So what we're looking at here is a motor neuron. It's the easiest one, and there's one in the lab that you'll look at too. And what it is, it's going to show you the basic parts of of your nerve cell. And what you can see, we have a cell body, we have our dendrites, we have our cell body with the nucleus, then we have our axon. And then you have your distal synapse, which is either going to be on a muscle or on a nerve. And this kind of, we talked about this. This would be connecting on a muscle, so that would be a neuromuscular junction, correct? And it's going to have acetylcholine come across, that's an AC. So the two neurotransmitters we care about in anatomy, even though there's like 6 in your body, is ACH and NE. And NE doesn't mean wing, especially, right? It means norepinephrine, so that you're addressing. Oh my God! It's like working in a TV center. Okay, so here we go with it. And what is this thing called myelin?
It forms the myelin sheath.
And what is myelin?
Myelin is.
What would you compare it to?
It's like an insulator. It's kind
Exactly.
of it makes it so that the inflammation can pass faster.
Exactly. You agree with that? She's saying yes. Because I don't know. So myelin in general is made like a fatty cell.
Yeah, I was gonna say
It's a lipid. It's connective tissue. It's a lipid formation. And it does. The more myelinated a nerve is, the faster it works. So you get a nerve like this. This is a truly heavy myelinated motor nerve, which most of them will be, and coming on your cortical spinal tract. And you're going to find this is your true white tract of the body. And this one here literally has the speed that this nerve could cover 100 meters in 1 second. That's how fast it is. So in your body, you're talking milliseconds to get around. So 100 meters is longer than a football field. 39 inches to a meter, 36 inches to a yard. So it's longer than 100 yards would be. So if you could run that fast, in 1 second you'd be in the end zone. Nobody would see you. That's how fast you move. Imagine 1,001, you're there. Or you were soccer player, every team in the world would want you. You'd be worth millions. Because on the kickoff return, you're going to score a touchdown. They're not going to stop. They're not going to catch it. It's just too fast. They want to. By the time they realize the play's over, you're in the end zone, standing there like, here I am, guys. So they have that ability. Now the gray unmyelinated fibers, which are your slow fibers, in 1 second will cover a meter, which is about 39 inches. So you look at a body, that's still pretty quick time. So you're still going to break down to milliseconds, even with the slow fiber. So your slow fiber would be more like with organs and things like that. You don't need them working with, your reflex response to pain or something to react. They're going to react slower. So you'd have the white and the gray. So that white fiber, when you first burn yourself and you pull your hand away, the gray fiber is the one that like, now this thing hurts, throbs, and you don't forget. It's like, ooh, that's your deep, unmyelinated fibers letting you know you really screwed yourself up. All right? And those are the ones that they use the opiates on to knock them out. The new receptors, that's what so many different receptors in the nervous system. That'll blockade them. That's what, so, each drug is designed to do different things to how deep it's going to medicate you to knock you out. That's what it's working with, okay? So that's the key of this fiber. And usually it's not going straight down. You have the nodes over here, and what it does is do this, boom, boom, boom. It skips, so it's quicker. It jumps from node to node. In comparison to an unmyelinated fiber, it's going to travel straight down it, which takes longer time to do this than this. So you skip a stone over the water, compared to gliding it over the water, skipping is going to go much quicker, because it's going to hop to get there. That's what it's doing. So you actually hop in the current down through it. So that's the basic anatomy as far as detail we're going to get with a nerve cell. Okay, we're not going to get beyond that. Not neuroanatomy. Now we're going into things that will make this stuff. Well, there's neuroglial cells in the body. And neuroglial cells are cells that are going to support, protect, and anchor this nervous system. So in other words, they have nothing to do with carrying electrical impulse. That's not their job. They're not nerve tissue. They're connective tissue in origin. So glial cells are connective tissue in origin. It's probably one of the most worst benign tumors you can get in the brain in a neuroglioma. Because why? It's going to root and follow all the connective tissue as it grows itself. It's not going to go from here to here, but it'll go in here and it'll just root itself so deep that you'd have to take the brain out of the person, open it up and scrape everything out. You can't do that. So they're very hard tumors to control and treat. Treat with radiation therapy and the Gamma knife, and they'll treat it with steroids. Keep the swelling down in the brain. But the unfortunate part is they still treat it the same 25 years later. That's the sad part. Some of these diseases we're still treating them like it's still 1970s. We diagnose them much quicker and easier, but we still can't treat it any better because we don't know that much about it. So the oligodendrite cell and the Schwann cell is similar, but this one's going to make myelin in the central nervous system, so this will be your brain and spinal cord. This is going to create it in the peripheral system, meaning your spinal nerves, cranial nerves. And you'll find the Schwann cell formation versus the oligodendrite heals better. When you damage a spinal nerve, you got more of a chance of it regenerating than you do in the spinal cord. For some reason, they stay in interphase a longer time than the peripheral system does. We thought, for years, you were trying to sell bio. Once you hit interphase, you got to go through your whole division interphase. It stayed there forever in your cell. That's not true. They do regenerate, but they're so slow, it might take 70 years to regenerate. You follow what I'm saying? In the central system.
That's a really long period.
Right, so the cell cycle lives a long time before it changes itself. So this is why you need stem cell research to treat spinal cord and brain injury, that you put new cells in there that will regenerate and grow quick to replace the damaged cell. And that's why, there's so much that you do need the stem cells. You need to use this stuff if you're going to fix these people. Where in the spinal nerve, it grows something like 1 microbe, or 1 nanometer, or 1, it's not big growth, but it will grow, so it will eventually regenerate itself. It'll take time, a few years, but you could get function back on a damaged nerve and extremity, depending on how bad your lesion is.
Have you heard about the new, I think it was Harvard, they just came out with this paper about it, where they're able to, it's like a little, it's almost like cash, but it's like a grid, and they're trying to figure out how they can use it with stem cells.
Right, to make it work, and you inject it in, and
it attacks itself over your brain, and it goes to neural levels.
and Yeah,
super cool.
it is. It is. It's all biomedical engineering. That's the future.
Yeah.
Instead of going to nursing, you guys should be going to biomedical engineering, things like that.
There's a lot of math biological.
That's what it is. If you don't like math, you can't do it.
Yeah.
And physical chemistry, PChem, not regular chemistry, physical chemistry, which is like a nightmare. The actual math of all these equations that you're working with. But the biomedical engineering field is your field of growth for the future. It's like how IT was. This is kind of like hitting its peak. The future, Microsoft stocks to buy a biotechnology stocks that are dealing with this type of innovative type care in people. You know, as long as the companies can survive themselves until they can overtake the pharmaceutical industry to get out there, they will eventually overtake. And it's like I said, the drug Afrezza that's out, that was designed to be the infusion of the way that the platform was bringing it into you was designed by Mankind. And Mankind stock was bought by Santa Fe Pharmaceutical, and it's an inhalable insulin. Works as efficient as our own insulin, but none of the injectables do. And it's titled as it lasts as long as you clear it out quicker in you, so you don't have that problem of over-insulating or not enough insulin in you. It worked perfectly in that prandial time of the hour and a half that your body needs to move the food. Well, they don't let it go anywhere. Why? Because what's going to happen to all these corporations making injectable insulin? Right, so they're not going to let that happen. So what they do, they tank that. So they took it and they tanked it. And a lot of endocrine, well, there's the other problem, is the endocrinologists won't change their way either. If I'm treating you with regular insulin and I got you well under control, I'm not going to take the chance of changing it. The only way it's going to happen, and it didn't happen, is the pharmaceutical company that owned it or bought rights into it, then advertised it on TV. If here you are going crazy, regulating yourself, injecting yourself 3 times a day, 2 times a day, and you see this new commercial, all you're going to do is this. Twice a day. What would you rather do? Stick a needle in yourself? Oh, that would bring you back, but they never did. They just took it and buried it. But I know. But now you have the pump you put on here where it just puts it into you and keeps you going. So what do you think the microglia cell is?
They eat the bacteria.
So if they eat things, what would their lineage be?
Immune system.
Which is white blood cells, right? So it's white blood cell lineage. That's what it would be, as a macrophage. We have those within our nervous system to fight off infection. And then you have the last one, the astrocyte. Now there's many more, and these have more than one function, each one of them. The key function, what we hear from anatomy, is what we're bringing out to you. In physiology, you'll learn that they have other things that they will do. But this, the astrocyte, the main thing we care about is synapse formation and nerve growth. So that's the one that will form the synapses and elongate the nerve to grow, is the astrocyte. This one is antimicrobial, and these two are for free or myelin formation. So what is the biggest demyelinization disease you know about? MS, right? That we hear about all the time, MS. Now they got new drugs they're treating it with. And the ironic thing, for years they always said MS will, become dormant, and you don't know you have it again, and it comes back. Well, now they're starting to realize through newer research that that's not the case with it. It's your nervous system's threshold starts shifting. And as it starts shifting itself, it doesn't take as much to realize the MS is there to affect you. So now the new meds that they're treating with is to keep that threshold above it, that it keeps the nervous system from being interfered with. Because what's happening, it's an autoimmune response to go in and destroy this myelin sheath, either in the brain or in the peripheral. And mainly it's the central nervous system that gets wiped out. It'll be the brain and the C-spine and the T-spine. And that's pretty much where you'll find it on MRI. MRIs make this so much easier to diagnose, because this was a bitch to diagnose. You'd have to rule out every other neurological disease. Then you finally came up with MS on a patient before the advent of the MRI. Because you couldn't see it. Now the MRI can see the lesions taking place where it's happening, plaque. So it's made it so much easier to diagnose this condition. You know, I've been seeing a shift of protein in the cerebrospinal fluid, inflammation cells in the cerebrospinal fluid. Doesn't mean anything. That can be anything else doing that too. Doesn't mean you have MS. So, you know, so the ALS and MS are in the same family, but ALS, amyotrophic lateral, all the lateral tracts get destroyed. And when that hits, that doesn't have remitting. That hits, and intensity just stays and keeps building. MS, a lot of people can burn out the virus that might have induced it. And after a 10-year time frame, most people can survive go on in their life. But the most common people to find it in, young females, 28, early 30s, either just had a baby. And that's what they blame it on, that stress created it, some type of stress situation in the body created the MS. But
They don't know what.
they don't know what it is. And a better thing I would base it on, because I had a young patient with it, she never had a baby, and I treated her for a neck injury a few years before, and she calls one day in the office, she's like all in tears, I woke up this morning, I can't feel anything from my belly button down, both sides. So, when she came in and examined her, and she had positive beliefs, so means when you push the head forward, feels like electrical impulse shoots down the spine. I said two things going on with her. You have MS, or you have a tumor somewhere in the mid-thoracic spine creating this. So I said, the next step, I'm saying MRIs on the brain, the C-spine, the T-spine. The MRIs come back inclusive of MS. So then you kick over to a neurologist that specializes in that. Because they're going to treat it the same way they always treat the cancer patients. They give it chemos, they give it, you know, they get this in, they get your immune system down. You want to knock your immune system down. But she kind of overcame it pretty good. To see it now, I would never have known she had MS. So we'll be fine. So, who knows? You know, that's, and there's other people that believe that the enzyme, the bee sting, they've done a study which shows combats the MS. So I had one, she didn't have her own bee bites on it. You go to this naturopath that had bees, little bee, and put the bee on you, and the bee sting you, you know. I said, ooh, on the back, you know, like 5 times, and she responded well. So, who knows? The earliest sign of MS, though, is optic neuritis. When you see optic neuritis, the first thing you're going to think of is you're coming down with MS. It means the inflammation of the eye, where you're losing your vision. They look at it, they can see inflammation around the optic disc, optic nerve is entering. You can see a demyelinization of it. That's the earliest sign that they go by for MS. Oh, you get clumsy. Start getting clumsy. Speech starts getting a little dysarthric when you try to talk on the phone words. That's another sign. So you start tripping and falling down all the time. Either that, just dream about one or the other. So then we get into the monosynaptic versus polysynaptic. Well, everything we've talked about up to this point has been this. Polysynaptic means there's more than one junction between nerves to get this information in and out of you. That's all that's saying. So we got more than one synapse. Well, we do. When we have the sensory system comes in, it jumps on an interneuron. It goes to the brain. It's going to hit an interneuron in the brain, and then from there it goes over to the motor side of the brain. It's another interneuron, descends down the spine, synapses on a motor neuron, and out they come. So you get at least 4 to 5 synapses before I make this move. It's hot, I pull my hand away. And it's amazing how fast that happens. But we need the brain for that. A monosynaptic communication means we have a direct communication between the motor and the sensory neuron in the spinal cord. We don't need the brain. Hence, you could be brain dead and still have reflexes. And grandma's not getting better from her stroke, but the reflexes are getting more intense. Most likely she's getting worse, and the brain is playing less influence on her spinal cord. So you'll see people, oh, look, reflex getting better. They get close, they get all that wonderful stuff. But no, she's not getting better. She's getting worse. And the brain is moving further away. Then eventually she doesn't go to shift. But that's, you know, the thing with this. So you will, just because you have reflex doesn't mean you're fine in your head. That's because your spinal cord's working. That's all it means. So you lesion the spinal cord, then you get nothing. But so this here is monosynaptic. So this is the true reflex. So it's like an eye. And if we look at the picture of this again, what's happening here, everything here you're seeing is polysynaptic. We don't have a picture of a monosynaptic. So a monosynaptic means this green one would come all the way and it would touch this yellow one. They would be meeting somewhere in the midpoint, and the current would jump across and get right on and come out. And how does it know to do that, you may ask? Well, deep tendon reflex is also known as deep tendon stretch response. And how the body knows to do that is by this thing down here called the tendon, or better named the GTO, the Golgi tendon. So the person sits there and you say, okay, we're going to do your reflexes now, and test out L4, and they tap on your knee, and you kick your leg out. What happens, that quick response on that tendon gives a quick stretch response. And the muscle realizes that if I don't contract against that stretch response, this tendon can rip off the bone. So it's a response to protect the body, your reflexes. So what will happen is when it hits it, you get this quick stretch response, and when it follows that specific, because it's firing on that GTO, it's going to fire a specific axon that's going to go up and meet a motor neuron and come right back out. So it arcs right across. It's like taking two electric wires and you put them close enough and boom, the current jumps across. Same thing's happening here. I'm not using the switch. I'm not using anything. I'm just putting my two wires close enough where boom, I make an arc and across. So that's your reflex arc. It's just arcing this current, one specific axon, from a sensory to a motor one, and right back out it comes. So it's a quick response. The other thing above you're seeing called your muscle spindle, that's where your muscle memory sits, in that spindle. So you get muscle, what's the biggest term used today by massage therapists in some PT? Muscle amnesia. Muscles forget. And what it means, not that the muscle forgets, these spindles in certain muscles don't fire anymore to let the brain realize they're still there. That's a better way of terming it. So this is why this Kinsio tape works, because it makes the brain very aware to keep that muscle spindle hyperfiring to the brain. So when you tape someone, you come down the muscle, you're going to follow the GTO into it. So you tape, when you came over this part of the muscle, when you know you're getting there with a tendon insertion, you're going to tense the tape over it, and you're going to relax it again, the tape. And the same thing on the top part of that muscle, you're going to relax it. So this way the tape will contract and relax with the muscle, but it'll always keep some tension force on my spindle. By doing that, it keeps the brain totally aware that I need to keep these groups of muscles firing so I stabilize the joint. And it works. That's how it works. And you put it on someone, minimum of 3 to 5 days, never comes off the tape, it's waterproof tape, and keep it on for 3 to 5 days. After the 5th day, you should be able to take it off, and the body will now remember that it needs to keep that spindle working. So that's the whole premise of Kinsio tape, or kinesiology tape. But it does work. So you see these athletes that were injured last week, taken out of the game, this week they're playing with this tape on them, and they play a couple of weeks like that, and then they're fine. They don't have it on them anymore. Because of because it's causing the body. And the weirdness is, when you tape someone up with this, who has like a moderate pain level, there's moderate pain there all the time with the joint, you put this tape on them, in about 15 minutes, they actually say to you, you know what? It doesn't hurt anymore while I'm walking. Because when you keep a muscle stimulated, you move in circulation. So you get waste product out of it. The muscles bring nutrition into itself. So it's the body's own way to regulate itself to stabilize the joint, without taking the living hell out of it where they can't even move the damn leg. So it has a better effect, especially on Achilles tendon injuries, when they're rehabbing them to get them better, knee, shoulder, or tendinitises in the elbows, it works tremendous.
That wouldn't work for like plantar fasciitis, right? It's not
No.
a joint.
No, because there's too much inflammation.
Yeah.
Just cut your foot off, but not push your foot. No, in that case, it won't help much. No. And then this picture here is just showing you a true, polysynaptic response. Sensory comes in, fires up, kicks on the motor system to work against it, but it's using an interneuron. So remember, in a polysynaptic response, you're using the interneurons. In a monosynaptic reflex response, no interneuron. Direct communication between motor and sensor. So there's a difference between the two. Okay, so that's just something in that. Before we finish, how many actually watch the videos of the cadaver dissection that are on live? Yeah, you see by our response, we get a lot of people watching this. I want to just, this was a pretty good video to show you. On the cadaver dissection. Takes about like 12 minutes long. If you bug you, you don't have to stay. You need to watch it. But you're actually going to see a cadaver getting dissected, taking spine. I'm going to show you some of the stuff you're going to be looking at in lab this year. Okay? So, but these are on blackboard for you, but I know nobody cares. And this one is the one on the hot. It's really good. It does help a lot. And Sue Groschel, she does this dissection with no gloves on. It's crazy. That teaches at this medical school out in Wisconsin.
I'm sorry, I put gloves on when I put videos on. It's not.
Well, you should. Well,
The vertebral column to see the joints that those muscles move. And then we're going to open the vertebral column to expose the spinal cord, which is protected within. As you first start your dissection of the back, you will clean up any subcutaneous tissue. And the first muscles that you see really are not true back muscles, but are called extrinsic back muscles. Because although they're located within the back, they're going to exit the back and move the upper limb. Some examples of those muscles would be a large muscle in the upper back called the trapezius. And if you reflect the trapezius muscle, you will find additional limb muscles deep to it, including the rhomboids and levator scapulae muscle. Okay? All of these muscles will be reflected to see the true back muscles that move the vertebral column. Lower in the back, we've got, again, a very large muscle that moves the upper limb called the latissimus dorsi muscle. And again, you will reflect these muscles on each side to really get to the muscles that we're interested in for this current dissection. Just to give you a better idea of how we reflected these superficial muscles, you simply need to take your scalpel and make an incision along either side of the midline, and that is the primary attachment of all these extrinsic back muscles. And by doing that and getting your hand deep to the muscle within a plane of some loose connective tissue, you'll be able to separate that muscle from the deeper ones and then simply reflect it back and out of your way. And again, we're going to reflect the extrinsic back muscles so that we can get to the intrinsic back muscles, which are responsible for moving the vertebral column. Now, there are several groups of intrinsic back muscles, and they've got very complicated attachments, but we're going to simplify it. If you first look at the muscle group in the lower back, you're going to see that there's a huge mass of muscle running vertically along either side of the column. This is called the erector spinae group of muscles. And you may read about different subdivisions to this group. We're not going to get into that detail, but simply talk about the erector spinae group that forms a large mass on either side of the vertebral column. Okay. And again, by just taking a scalpel and cutting down on either side of the spinous processes of the vertebrae, and then using a chisel to scrape that muscle away from its other attachments, you will be able to reflect that entire group of muscles to expose the vertebral column itself. Okay, so this is the erector spinae group of muscles that's particularly well developed low in the back. If we now go up to the cervical region or the neck region, you'll find some additional intrinsic back muscles. The most superficial group at this level would be a muscle called the splenius capitis muscle. And if you take a look at the orientation of the muscle fibers here, you'll see that they essentially form a V on the back of the neck. So the fibers are angling from the midline upward and laterally as they approach and attach to the skull. Again, by cutting along the midline, the attachment of the splenius muscle, you can find a deeper group of muscles. Now again, if you take a look at the orientation of the muscle fibers, you'll see that these are running more vertically along either side of the column. And this muscle is called the semispinalis capitis. All of these extrinsic back muscles are going to be responsible for extending the spine and also for rotational movements of the spine. Now, as an orientation to what you're going to be doing in the next step of the dissection, we've got an articulated vertebral column here, just so you can appreciate some of these surface landmarks that you see on the cadaver. Now, these bony processes that are extending out posteriorly are the spinous processes right on the midline. Those are for muscular attachment. And then if you look closely at these vertebrae, you also see additional processes, the transverse processes, again serving as muscular attachment points. Now, you might need to look a bit more closely to see that there are joints between the pairs of vertebrae here at each level. So there is a limited amount of movement at each intervertebral joint. This is an isolated vertebra to show you some of the parts that you're going to be removing and cutting through during this next dissection. This is the body of the vertebra. You're going to find that on most of the vertebrae along the column. And then there are some portions that form the boundaries of this vertebral canal, the spinal cord being housed and protected within the vertebral canal. Now what you're going to do to expose the spinal cord and its branches is to cut through the bone of the vertebral column and remove it so that you can see inside. The part of the bone that's attached to the body and extends posteriorly is called the pedicle. And then the portion of the vertebra that forms the roof over this vertebral canal is the lamina. Where the two laminae meet, that's where the spinous process forms, and where the pedicle and lamina meet is where the transverse process forms. And you're also able to see the articular processes that will form joints between the sequential vertebrae. Now, one thing to pay particular attention to is the size of the vertebral canal. It's perhaps about 1 centimeter in diameter, so as you're making your saw cuts through the laminae on the cadaver, you need to be certain not to make those cuts too wide. And for example, if you get a little bit too wide with your cuts, you may only be cutting off the transverse processes and doing nothing to get into the vertebral canal and expose the spinal cord. So I would estimate that about 1 centimeter wide would be what you're going to cut and remove from the vertebral column to expose the spinal cord. And there are the spinous processes of the vertebrae, and your goal is to remove the spinous processes and laminae along the entire length of the vertebral column. So the first step in this process, after you've cleaned away as much of the soft tissue as possible, is to take a saw and score along the entire length of the vertebral column. Okay? Just lateral to the spinous processes, cutting through the laminae. Okay? And this should ensure that you expose the spinal cord and the surrounding tissues without going too wide. Okay? After you've done that initial saw cut, which should be relatively shallow, you want to finish the removal of the laminae by using a chisel and a hammer. Okay? So angle the chisel in medially, and then use the hammer to continue going through the bone and ultimately remove the vertebral column piecemeal along the entire length, and you will expose the spinal cord and surrounding meninges within. We've completed making the cut through the laminae along the entire length of the vertebral column, including down into the sacral region. So you may or may not be able to pull the entire portion of tissue off in one piece, but in this case we can. So now we're removing the laminae and the spinous processes of the vertebral column. Now what you see inside is not the spinal cord immediately, but some of the tissue that surrounds the spinal cord, one of the layers of the meninges, the dura mater. And if we incise that, we can see the other 2 layers of meninges inside this and see the spinal cord itself.
So there's 3 minutes before you get to the spinal cord.
It's very easy once you get into the dura mater to simply split the entire
Cutting the
length
dura
of it
mater,
open
take outside.
with the scissors or even a
Next
probe.
one will be the arachnoid, which show you that. And under that arachnoid, we'll see where your cerebrospinal fluid is, and she'll talk about this.
I can't really hear it because everyone's putting their stuff away.
Huh?
Can't really hear it because everyone's putting their stuff away.
Now, pulling the edges of the dura mater aside, you can start to see some of the other meninges surrounding the spinal cord. And the next layer that we would encounter is the arachnoid, and that is this very flimsy layer that is collapsed onto the surface of the spinal cord that you can just barely see. It's very delicate, and it is collapsed away from the dura mater because the fluid that normally holds it there is
So
no longer
right under
present.
that is where your cerebrospinal fluid is. So when they do a tap, they
By
go through those
moving
two
that,
ways to get in.
Now, you
to
don't see
draw the
anything
fluid out.
distinctive as the innermost layer of the meninges, the pia mater, but that would be attached directly to the
Here
surface of the
now
spinal
is
cord
like
itself.
glued right to the nervous tissue.
As you
You
get
can't
into the
separate
vertebral column, you want to look at the meninges and the spinal cord. It's helpful if you cut away some of the dura mater and reflect it out of the way so you're not constantly having to hold it back and out of your way. As you do get that revealed, again, you see the arachnoid, which is collapsed on the spinal cord, and you dissect it from that way. But one thing that's striking is if you look at the spinal cord itself is that it's significantly shorter than the vertebral column itself. In fact, it ends approximately at vertebral level L2, so that as we look at the spinal cord here, it becomes narrower and narrower at its inferior end, forming a structure called the conus medullaris,
Because it ends like a
this
cone shape.
inferior cone-shaped structure.
And we'll learn these
Extending
terms
directly
about
off the conus medullaris, you're going to find a strand of tissue called the phylum terminale. That is a specialization of the pia mater, which anchors the spinal cord to the coccyx and runs inferiorly within the vertebral column to do so. Some of the other structures that you see mingling with the phylum terminale here are collectively called the cauda equina, and they are dorsal and ventral nerve rootlets that will form spinal nerves
That's the
forming
cone.
at sequential vertebral levels and exiting the vertebral column so that the entire body receives innervation. Now, if we go back up to slightly more cranial levels, we can see how each spinal nerve is constructed. Now, zooming in here at the spinal cord itself, you can see these strands branching from it. And now, of course, we're looking from the posterior or dorsal side. So what you see first are the dorsal rami. Those are the sensory nerves that contain sensory information going back to the spinal cord. And you can also get a glimpse of the ventral rami, which branch
Those are the
from
two
the
things
ventral
you'll
or
see in
anterior
that
side of the
cross-section
spinal cord,
here.
carrying motor information.
She's gonna show
Now, at this particular level, we've got a very nice example of another specialization of the pia mater called the denticulate ligament. This also helps to anchor the spinal cord and hold it in position. And the denticulate ligaments come off the lateral edge of the spinal cord, run right through this space, and anchor the spinal cord to the dura mater. It's nice to use those as a landmark because you're going to find them separating the dorsal rootlets, the sensory rootlets, from the ventral rootlets or the motor rootlets. Now let's follow those dorsal and ventral rootlets away from the spinal cord, and ultimately they will come together to form a spinal nerve from this level. Okay. Following them away from the spinal cord, as you get to the position of the intervertebral foramen, there's a swelling here which represents the dorsal root ganglion, and that is where the sensory nerve cell bodies are found for those axons that are traveling within the dorsal root. Now, following away even further, you're going to find the major branches of the spinal nerve. The spinal nerve itself, where all the motor and sensory fibers are together, is very short. It's about right here, maybe a couple millimeters long. And immediately what you're going to find is that spinal nerve branches into a dorsal ramus, which is quite small because it only innervates the deep back muscles or the true back muscles and provides cutaneous innervation as the posterior cutaneous nerve. The ventral ramus is much larger because it's got a much greater territory to supply. This is the nerve that wraps all the way around the body wall, gives out the lateral cutaneous nerve that you saw in the last dissection, and also the anterior cutaneous nerve that you saw in the previous dissection. The other structure that we can find here is a nerve that you see heading straight anteriorly. Now, we can't really see what it connects to, but just keep in mind for now the position of this branch and the fact that it's called a communicating ramus, which will link this spinal nerve to the sympathetic trunk, part of
That's how
the
you
autonomic
bring
nervous system.
electrical impulse into the sympathetic system.
We've used a scalpel to cut a
Now
small
look how
section
small
of
it is.
the
That's just
thoracic
spinal
wall of the
cord
spinal
against a
cord.
dime.
And you can see the small size of it relative to a dime.
Here's the H pattern in the middle,
For its
right
size.
here. So that would be a
And
white
the
kidney.
structure that you see in the spinal cord is actually pretty limited.
It's like
You can see the distinction between the gray matter and the white matter. Confusingly, the gray matter is central and it looks lighter in the embalmed specimen, and the white matter, which is around the perimeter, has a darker appearance to it.
But it's amazing how small it is and what it does. That's the point I want you to realize. You're not talking a big area. You're talking something small and your little finger to the size of your mouth.